practices with his wife, also another Sherman graduate, and also
I wonder who that is.
Dr. Alcantara. Many people may know Dr. Alcantara. He's a research director for the International Chiropractic Pediatric Association, chiropractor with a PhD in health science from Southern Cross University from Australia. His research focus for the ICPA includes safety and effectiveness of pediatric, perinatal, and general family wellness. Ladies and gentlemen.
Come on. Bring it.
Happy Saturday, everybody. What a great day to be here. I'll tell you, let's first show a little gratitude. I don't know if you've noticed, but this amazing gentleman right here, Dr. Alcantara, he's been in 4 of these presentations. So I won the Dr. Joel lottery. He came up with me. That's a little bit of jealousy back there. I'm grateful to have you here. Thank you so much. Without him, this presentation wouldn't have happened. I would also like to thank Sherman College and the sponsors of this event. Without you, this wouldn't have happened either, so super grateful for that. And on a personal note, I want to thank the instructors that are here, that are still teaching for me when I was here, that had a role in influencing who I am, what I've become as a doctor. I can't even begin to give the gratitude and love that I have, the appreciation for their service, dedication to the school, to the profession, to us individually. I'm just super grateful. Thank you so much for that. Also, I'd like to give a special recognition for Dr. Alan Brewster. You're doing a great job emceeing this thing. Thank you so much. Really, really appreciate it. You know, he came to me, he says, Dr. Baker, I know you teach these seminars and they're really long. Like the shortest one I do is 14 hours. And he says, look, Scott, you absolutely can't go past 2 hours today. I don't know how I'm gonna do it. We're gonna give it a shot though and see what happens. I know when I started my chiropractic journey many, many years ago, I was young and I was broke. But I'm here to tell you, after years of hard work and perseverance, I'm no longer young. The question, we're taught this, we're quizzed on it, we're expected to know it for our board exams. Degenerative disc disease, is it reversible? Is it curable? The answer, what do you guys think? Yeah. What are we taught? And what are we expected to get the answer for? To get our license to tell them that it is not true? That's a great question, right? The technique that we use for this study is Blair technique. How many here know what Blair technique is? Oh, great. Okay, so it's an upper cervical technique. They're kind of the rebels in the upper cervical technique. They go all the way down to C5.
Get out of here.
Right, so they're way out there. They have a system for adjusting, analyzing, and all that stuff. Based on asymmetry. It's a articular technique too, so looking at the articular joint itself. And these are just some examples of some of the asymmetry here that we'll see. Dr. Blair is a Palmer grad. He had a lung condition, and his wife turned him on upper cervical care. They got rid of the lung condition. He's super excited, so he went to school, became a chiropractor, and has advanced BJ's work mainly from the side posture toggle and from the Nasium views. He created these protractile views that are based on convergence angles of the condyle to allow so you can see the overlap of the AO joint, which causes pressure on the nervous system. There's a society right now, and I think there's probably around 300 active doctors. So the things we're looking for here are structural misalignment, basically the AO, the AA, the central, like I said before. The performance of the central nervous system. So some of the objective findings we do in our office, we do the Hytron scan. Most of you are probably familiar with that. What about right eye? How many people here know what the right eye is?
Is that the concussion?
Right, it's really cool. Kessinger would love this thing because it does the neurological eye exam, so it checks pursuits, fixation, saccades. Really, really cool. We do blood pressure, pulse rate, oxygen saturation, and then a non-either, I never can say that word right, but it's a grip strength test. we do dual scales as well too. So the muscular balance stuff, dual scales, range of motion, got the Roger Tights on range of motion thing, muscle test, pressure test. So we do a lot of different tests to know what's going on with the person, and then of course we take them through to find out when and when not to adjust based on pattern analysis. That's what we do. So one of the things we kept noticing very consistently is patients' improvements in their symptomatology would just kind of clear out. The structural position would change. We saw positive change in the disc height in itself and the degeneration as a total. And so as you see here in this first one here, the measurements in between are in the yellow. The lowest ones here at 2.6, 3.2. You can see in the 6.4, 5.6. That's a significant growth. So this would be the first one here, 3 months, 6 months, and 12 months. We were trying to figure out, hasn't even done any research on this before, and we reached out to Todd Hubbard, who has like all the research for Blair's, a good guy over in Palmer. If you don't know him, he's a neat guy. He said, yeah, no, nothing. We looked at all the different stuff, so we're like, okay, nothing's been published on this. Except, I think it was yesterday, Dr. Kent came up because, Scott, I'm really looking forward to seeing your presentation. I go, nobody's done anything like this in years. I'm like, oh, somebody's already done this. He goes, yeah, I think it was like back in the 70s, I think you said. And they said, but I said, what happened? He goes, well, the board tried to get him because they didn't like when he was presenting. I'm like, perfect. I'm the one. Yeah, that's it. So let's see. Okay, so the things we're looking for, disc height. And so we kind of did a triple study. So it wasn't just disc height, we also threw in the curve and also anterior head carriage as well. Life University, thank you for being our IRAP. This is a 1-year retrospective. So basically, I've got thousands and thousands of pre and post x-rays because I've been doing this for a bit now. So I have 10 years on the DR system, and so I was like, presented that to Joel. Joel's like, that's too much. I go, what do you do? And he says, well, take a small sample group and follow them for years. So we took 3 months in 2022. And we tracked them for a year. We had 45 new patients. Of course, we didn't add the children, so the children were in, so it's 18 and older. Some of the demographics that we used. And that's basically what we're looking for. That's what we're examining here. So I was going to show you, this is how I did it, so you can see what we did. So we used a software called Radiance USA, or Experu, or something like that. Anyways, we go in and the computer basically has these programs, and we just kind of follow what they want. I think these are like what's called George's lines, right? Not mine, not the George's line. We just follow down, and then it'll do the math for us here once we drop our dots for the anterior head carriage. That's it. Here, we're measuring the lordosis of the curve. So we'll put a dot up here at the top of the bends, one down halfway down, and then one down about 4 more seconds, getting a measurement from there, looking at what the curve would be. I think normal curve should be between 150 and 160. If there's such a thing as normal, that's kind of the question. And then once the disc space goes, this is what we did here. Well, the first two, we were very consistent, so we expand them to 50% zoom on the first two. This one, we go to 85% zoom. So we're always doing the same zoom because, as you know, there's going to be fallibility anyways for humans, right? We make mistakes. But we're just dropping here the inferior body, and then on the posterior part of the body, just in between measure that space, the opacity, really to see what's going on. The lucency, not the opacity. Almost got trouble with my x-rays right there. I wish you could see that. And so we get these measurements in between, and then of course we take new images in 3 months, 6 months, and 12 months, and compare them. And then we just zoom back out, and then we've got measurements. So here's one of the cases that we have here. 52-year-old male, professional musician. He came in, that's all symptomatology up there. They run through 10 questions. And generally, once again, this is kind of just a general observation. Usually between 3 and 6 months, 85 to 100% of symptomatology seems to clear out. It's kind of an interesting side effect of what we do. So in this one here, you can see the anterior head carriage. Started out at 56, ended up at 52. Not a giant change there. cervical curve, 154, 153 pretty much stayed the same. But if you look at the intervertebral disc space, growth, all the way through. You know, that takes pressure off the nerve. That doesn't make sense that they would get better. 31-year-old female, single mom, esthetician. Same thing, the original images here. Almost reverse curve, military neck. Her curve really changed quick, which is really cool. Younger kids too. I wish we had some of those. I'd show you those. The young ones really changed fast. Of course, you can see she had a pretty healthy disc image because she was fairly young. But look how much thicker they got. They got much thicker. Here, this is a 77-year-old grandpa, kind of a golfer, real nice guy. South Africa, really good guy. Anyways, here, once again, as they get older, they have the anterior head care. It's not a big change in the anterior head care at all. In fact, it seemed to be a little worse. Curvature stayed pretty consistent, but it did get down to what I would consider what we're looking for as a normal 150 to 160. And once again, look at the individual disc spacing here. In the growth. It's really cool to see these changes happen. And of course, the pathology is better and better. For a lot of times, though, truth be told, as they get much older, and this situation's been there longer, then really we're helping them suffer less and live more. That's really the big picture. And this is your kind of show up. We'll explain that to you.
All right, are you guys ready?
Yeah, let's go.
Everybody take a deep breath. I don't know if you guys want to speak statistics on what next. No, I'm just kidding. So, Dr. Baker from the retrospective file review here, and basically we looked at 45 files, and he came up and he said, I've got hundreds. I said, to make the iced tea sweeter, you don't need to add 5, packets of sugar. One will do, maybe 2 will do. So we looked at 45 files. The average age of the patients was 51.98 years. And as you can see here, they came in with a variety of musculoskeletal complaints. And we just decided to look at the MSK and leave out the non-MSK. And as Dr. Baker said, they basically all improved in terms of their clinical presentation.
Oh, you broke it.
So that's why.
We get a little help.
Okay, so, looking at the numbers, and again, everybody here is familiar with millimeter changes type of measurements. And basically what I did with the statistics is to look at the numbers and how would it complement the clinical findings, right? Everybody is familiar with improvements in patient care, with chiropractic, but what do the numbers really show? Because as the saying goes, the numbers don't lie, right? So as you can see here, Dr. Baker measured the intervertebral disc in the cervical spine from C2 to C6. And here's the first two between C2 and C3, and C3 and C4. And as you can see with watch plots, there is a trend at various time points of an increasing intervertebral disc height. But what does this mean in terms of the statistics, right? So the appropriate statistics for this is called the analysis of variance. And if you recall from your introductory class in research methods, it's basically examining whether the means in different groups are different in a statistically significant manner, right? It's not just by chance. But here, however, what Dr. Baker did was look at a group of patients and measured their disc height at different time points. So they're not different groups, but it's the same group receiving the same intervention of Blair technique at initial care, 3 months, 6 months, and 12 months. And this is what we call the one-way analysis of variance. And basically what we found in terms of our analysis is this is what they call an ANOVA table. And it's not going to make much sense to everybody here, but everybody here is familiar with the p-value, right? Yeah. The smaller the p-value, the more likely you're going to reject an null hypothesis or the hypothesis of no effect. In other words, what we set up is basically, I looked at Dr. Baker's work and said, let's accept the null hypothesis, that there is no effect. And then we went and looked at the data, I did the analysis, and basically we looked at the p-value, which is the probability that these numbers came out by chance on the assumption that Dr. Baker's care had no effect. And as you can see from the number, it's very, very small. The probability that these numbers came up by chance is very, very small, and so we can reject a null hypothesis, meaning to say that Dr. Baker's work with these patients actually increased their disc height beyond statistical significance. So this complements the clinical significance that we observed in the clinic that these patients not only got better, but their disc height also increased. Okay, everybody following so far?
Yeah.
All right, so we did this at each level, and as you can see here, the p-values were very, very small. That this isn't just happening by chance, right? Some of you may notice the f-value, and you're asking, what does that mean? Well, this is just another one of those statistical tests where they say, they looked at the groups and they basically said the variability between groups is much larger than the variability within each group. You have to remember, we had 45 patients, and we measured the mean value for each group. Okay, but again, my take-home message is look at the p-value. It's very small. That means there's a very small chance that this is happening, right? The probability that this is happening with the assumption that the intervention of Blair technique had no effect, and we're going to reject the null hypothesis. So C4, C5, again, we see the same trend, right? We're thinking, well, maybe at various levels it's going to change, but maybe not all of them. And for me, I was quite surprised to find that at all levels of the cervical spine, the intervertebral disc change. Right? And I know Dr. Baker is going to talk more about this in terms of the discussion, but you can imagine what are the improvements of increasing the disc height. Right? Or ask the other way of asking that question, well, what is the detriment when the intervertebral disc height decreases? Okay, so again, one way repeated measures, analysis of variance, C4, C5, C5, C6. Again, the p-values are very, very small. We reject the null hypothesis, and basically the last intervertebral disc, C6 to C7, we find the same thing. Now, we also looked at the cervical lordosis. Now, interestingly enough, again, as you can see here, there's a little bit of change. You know, from the initial care to 3 months, 6 months is a little bit of an increase, and then again, it decreases at 12 months. And we did the analysis, and unfortunately here, I was quite surprised, because again, I'm thinking, well, you change the intervertebral disc, you change the biomechanics of the cervical spine, you know, all these other measures would also change as well. And surprisingly, again, as you can see here, the p-value, it's not less than 0.05, it's a higher p-value, so we failed to reject the null hypothesis. In other words, changes are not that huge or large from the initial to the final measures of cervical lordosis. In terms of the anterior head carriage, again, you can see the measures here. There are some changes, but when we look at the numbers, in terms of the analysis of variance, the p-values are very large. It's not less than 0.05, so we failed to reject the null hypothesis. So overall, we see changes, but the most significant changes statistically as well as clinically is in the intervertebral disc height.
Thanks, Phil. Appreciate that. So the question is, we're taught, we're told, we're tested, and we're supposed to accept that this is not something within the realm of chiropractic, when it absolutely is. Here's the fun part. This isn't a plug for Blair. I've talked to many doctors on many different techniques, and they're telling me the same thing. So wouldn't that be cool to get a larger study with the different techniques, the different upper cervical techniques, different full spine techniques? Let's see what's really happening here, because if we're the ones doing it, we should be the only ones referred to it. Right? Because right now there's supposed to be no cure for it, and just medicines to cover up the pain. So the advantages of the growth that we're seeing, you know, I mean, I'm a pretty simple guy. Bone on nerve, bad. Bone off nerve, good. Right? It's pretty simple. And people, when the bone comes off the nerve, they just get better. And they also hold longer. There's a bit more to that. Maybe we'll talk some other time. But when they hold longer, they heal more. They're stronger all the way through. And, you know, the relief of symptomatologies, I mean, that's what they all come in for, right? Nobody comes in and says, hey, will you align my spine because I want it to look nice. They come in because they're suffering. And as you saw in that earlier study, 83% of these children coming to the world right now are being violated for one reason or another. And that assault on that neck, and that's their life. And they usually don't show up to us until years and years later, suffering needlessly, and it's up to us to step up and reach them. I'm running out of time. You guys get this, the big picture, right? If you have any questions, I'd have to answer them if you want, but the big picture is what we're here to help people. This is all about them, not us. Yeah.
Okay, my name is John. Just to clarify, Blair is an upper cervical technique, and even though you're adjusting the upper cervical spine, you saw changes in disc height throughout the entire cervical spine. Did I get that right?
We also take full spine and weight-bearing x-rays and posing views on every single patient, and we have all of that data too. And like, the data coming from functional scoliosis is just incredible. Yeah, we're seeing change all over. Yeah.
Did you see any changes in osteoarthritic spurs or anything like that being lessened as that process continued?
Yes, so we've seen some pretty cool stuff. I've seen actual natural fusions open up. I've seen very, very few cases, maybe one or two cases where the lipping and spurring actually reduced a bit, right? But I've seen partial fusions and full fusions actually open up as well too. So yeah, I mean, one of them was an 84-year-old guy. I've gotten lots of patients now. We don't do those the labs for it. We'll do the DEXA scans, and they'll come back and say, hey, you know, I did my DEXA scan, and I no longer have osteopenia, or I'm from osteoporosis down to osteopenia now. So, I mean, the things we could do are endless, you know, as far as testing it goes. But yeah, it's cool. You release life does its thing, doesn't it? Yeah, it's really cool. Right on. Thank you very much.